What I'm going to try to do is to convince you that asynchrony is a problem, and that it happens, and it happens in every single patient you mechanically ventilate who you allow to interact with the mechanical ventilator. There are things we can do to minimize the level of asynchrony, and clearly there is some relationship of asynchrony to your choice of modes of mechanical ventilation, but it's something that exists pretty much across the board. In most cases, not an issue because it's at a low frequency, but clearly there are other circumstances where the level of asynchrony is way too high and clearly has a potential impact on affecting in a negative way patient overall outcome. So my conflict of interest statement, I have relationships with a number of companies. We're not going to talk about any technology today. We're simply going to talk about, application of mechanical ventilation. So this is my approach to categorizing different types of asynchrony. I think it's pretty consistent with that of most other individuals, that I've listed 4 different categories: flow asynchrony, trigger asynchrony, cycling asynchrony, and mode asynchrony. I've highlighted 2, flow asynchrony and double triggering, because those are the ones that, at least in my opinion, have the greatest potential negative impact on patient outcome. Because if flow asynchrony exists, as we'll see later, you can have tremendous changes in transpulmonary pressure that you may not even realize. And of course, if double triggering occurs, you can end up delivering tidal volumes that are twice what you set on the mechanical ventilator. So clearly, obviously, circumstances where the probability of a negative impact is very high if they occur on a regular basis. Under trigger asynchrony, a whole lot of different categories: trigger delay, double triggering, mistriggering, auto triggering. Cycling asynchrony refers to just the coordination of ending the breath by the ventilator and the patient simultaneously. Biggest problem in pressure ventilation, much more so than in volume ventilation, and of course, mode asynchrony. I hope to convince you that your selection of mode does have an impact on asynchrony. So when you look at the classic modes of mechanical ventilation, depending on which mode you're making reference to, you either set pressure, flow, volume, or time, or a multitude of those. And as you can see, when you go from volume ventilation to pressure assist control, to pressure support, to NAVA, the amount of control changes. Volume ventilation, because of the way we deliver volume ventilation, has the greatest probability of causing asynchrony. Why? Because how many of you can breathe with a tidal volume of 400 ml, an inspiratory time of 0.8 seconds, with the square wave flow pattern every single breath? You don't do that. You have a tremendous amount of variability in the way you ventilate right now. You do not have a consistency in your ventilatory pattern. And to expect patients to be able to tolerate that approach to ventilation is very difficult. When I deal with my own staff or I deal with residents, I make them breathe on the ventilator. Give them a mouthpiece and a filter, and set the ventilator the way they would set it on a patient, and see how well they can tolerate and how difficult it is to tolerate a mode of ventilation that exerts this much control over every aspect of ventilation compared to one that exerts minimum control over the process of ventilation. So as you go down this schema, you would expect that the amount of asynchrony decreases. And clearly, when you look at the literature on PAV and NAVA, in which none of these variables are set. Remember, with PAV and NAVA, there are modes of ventilation in which different ways, but we set the proportion of effort that's provided by the ventilator. In every one of these modes, the patient must follow the lead of the ventilator. In PAV and NAVA, the ventilator follows the lead of the patient, which makes a huge difference in the interaction and the amount of comfort patient's experience if you use this mode of ventilation or these modes compared to these other modes of ventilation. I think it was very nicely depicted by Magda Yunus back in 1992 in his first publication about PAV. He did this graphic, which still holds true today, looking at patient effort versus the amount of pressure that the ventilator develops. And if you look at volume ventilation, you have an inverse relationship between the amount of pressure developed by the ventilator in relationship to patient effort. The greater the patient pulls, the less the ventilator is going to push. Why? Because the ventilator doesn't care how the air gets into the patient. You have designed the settings to deliver 400 ml, and whether the patient pulls the air in or the ventilator pushes the air in is totally irrelevant. I can take a lung model and set that lung model with enough inspiratory effort that airway pressure won't go above 0 during the inspiratory phase. You see that in some patients, not to that level of exaggeration, but when you look at flow asynchrony circumstances, that the amount of pull on the part of the patient is such that very little pressure is actually developed to assist the patient during ventilation. Pressure support and pressure assist control, you have a constant pressure, regardless of what the patient is doing. Obviously, there's some variation in reality, but theoretically, you have a constant pressure established. In PAV and NAVA, you have a direct relationship. The more the patient pulls, the more the ventilator pushes. Why? Because you set the proportion of effort that the ventilator is going to provide, 40%, 50%, 60%. So no matter what the patient does, you get that same proportion, but obviously it's going to be higher the greater the overall effort on the part of the patient. And basically, all we're doing is setting the slope of this curve when we deal with PAV and NAVA. For a small patient effort, do we get a big response? Or for a small patient effort, do we get a small response, from the ventilator based on what percentage of unloading you have selected in that given patient? So, volume assist control. Theoretically, this is what it should look like on all of our patients. Assisted breath, controlled breath. When the breath is delivered, you get a pressurization of the circuit, usually without any significant volume change at the beginning, depending upon the patient, maybe a small or a lot of pressure. And then you should see a relatively linear increase to peak airway pressure and then exhalation if you're in a square wave flow pattern. John Marini, now long time ago, over 30 years ago, showed that in most patients who are on volume ventilation, you don't have that type of airway pressure waveform when the patient is assisting the ventilator, or the patient is breathing spontaneously. So what he did was he went up to a bunch of patients on assist control, measured the airway pressure versus time waveform, sedated those patients, and then remeasured it. So here is the remeasured controlled breath. And he argued that if the assisted airway pressure curve was the same, then the work provided by the ventilator during assisted ventilation would be equivalent to the work during controlled ventilation. But this is what he found. This was the airway pressure curve during assisted ventilation, and I'm positive you've all seen that in patients on assist control ventilation, where you have a significant decrease in airway pressure during the inspiratory phase. You have a lengthy period of time before airway pressure returns to baseline. You have a concavity in the airway pressure graphic in which the pressure is much less than the pressure was under controlled mechanical ventilation. So in this study, this was the work that patients were doing. This was the work that the mechanical ventilator, was providing. Obviously not, in my mind, the ideal way to mechanically ventilate patients, that we should be unloading the patient every breath, and we should do whatever we can to avoid, this type of a circumstance. So one of the other things that, of course, needs to be considered as we look at that is a relationship between peak flow, inspiratory time, and patient ventilatory demand. Critically ill patients tend to breathe with a pretty short inspiratory time. I mean, all of us are breathing with an inspiratory time of much longer than 1 second. Few critically ill patients do that when they're stressed. They have inspiratory times maybe 0.5 to 0.8 or 0.9, depending upon the level of stress, but they rarely have inspiratory times greater than 1 second, if they're triggering the ventilator spontaneously. So this graphic is one patient. So we have airway pressure, we have flow, we have volume. This is the raw EMG signal of the diaphragm. This is an integrated EMG signal representative of effort. And this is esophageal pressure turned upside down to imply the amount of work that's actually being performed. So the greater the area under the curve, the greater the amount of work that the patient is doing. So if you'll notice, volume is constant in all of these columns. What's changed is the peak flow and the inspiratory time. Higher peak flow, shorter inspiratory time, airway pressure waveforms that are much more consistent with circumstances where patients have minimum work. And if you look at the indices of work, much different than they were here, where we had a concavity in the overall airway pressure waveform. So we can manipulate it. Doesn't always work on every patient, as you well know, but paying attention to the peak flow, the inspiratory time setting, and doing as much as we can to adjust the two to meet the patient's ventilatory demand can minimize the amount of flow asynchrony, and some patients maybe eliminate it in total. In pressure-targeted ventilation, the same thing can happen. This is an old study, volumes way too large, by Neil McIntyre. But the issue was to look at the way volume ventilation was pressure ventilation was delivered and the use of rise time. With pressure ventilation, rise time adjusts the speed with which flow goes from 0 to the peak level. This was what they considered the optimal rise time, excessive rise time, minimal rise time, where you had the same concavity associated with volume ventilation because the flow was inadequate to this particular patient. And in every mechanical ventilator that I'm aware of today that delivers pressure modes of ventilation, in all pressure-targeted modes of ventilation, rise time is operational. So it allows you to vary how quickly flow goes from 0 to maximum. And in doing that, there is some change in the peak flow that's actually developed. And what we should be doing is making that adjustment in order to ensure that the delivery of pressure-targeted ventilation, again, doesn't result in flow asynchrony. So in both pressure and volume, you have means of minimizing that level of asynchrony, although I'm not sure that it's always paid attention to as much as it should be. As you know, patient status change constantly, and almost every time you walk in the room to see the patient, if they're actively breathing, you have to make some kind of adjustment in order to bring these back into a circumstance to minimize patient overall effort. So I wanted to spend a little time on this study that was done up in Canada by a combination of groups, the Canadians, a group from Japan, Marcelo Amato's group from Brazil. And what they did was they looked at in animals and in one patient the differences in esophageal pressure compared to pressure measured using wafers that were put inside the pleural space. They put wafers that were least gravity dependent, wafers that were most gravity dependent, and then put an esophageal balloon in to look at essentially the midline, level of esophageal pressure. What they were investigating was this hypothesis that many people had, that during assisted ventilation, volume assist control results in a less injurious pattern of inspiration and pressure assist control, because if the patient pulls, the peak pressure decreases. So you have the same transpulmonary pressure. It's just distributed in a different manner. So this is one of the graphics from that paper. So let's start over here under controlled mechanical ventilation. This is volume assist control ventilation with muscle paralysis. You can see airway pressure, flow, overall tidal volume, and then here distribution of tidal volume to non-dependent and to dependent lung. And as you'd expect in somebody under controlled ventilation, we get much more distribution to non-dependent lung than we do get to dependent lung. Here we have volume assist control, and here we have pressure assist control. Again, pressure, flow, overall tidal volume, but look at what happened to the non-dependent, region of the lung in both of these circumstances, in both volume ventilation and in pressure ventilation. Essentially, you have a significant amount of pendulough during the inspiratory phase of air moving from the non-dependent to the dependent part of the lung. And as I'll show you in a second, the reason for that is that the pressure generated in the pleural space in the dependent is much greater than the pressure generated, that's where we normally measure at the esophageal level in patients with any level of lung consolidation. But it occurred in both volume and pressure ventilation. So they argued that either of these can be injurious. If you allow a patient to breathe vigorously and the ventilator is not matching their demand, we can set up a circumstance where we can induce injury by either hyperinflating the more gravity dependent or creating a greater transpulmonary pressure gradient in that area. But look here in volume, the level of flow asynchrony. Here's where inspiration began. Here's where inspiration ended. No positive pressure was ever developed. That positive pressure was developed as the patient, or in this case an animal, transitioned from inspiration to the expiratory phase. So this is what I was making reference to. This graphic represents the gravity-dependent wafer that they put in these animals. Here represents the esophageal pressure, and on top of it, which you can't really differentiate, the non-dependent wafer. There is pretty close correlation between the non-dependent and the middle, but there is a huge difference in the dependent wafer. The reason for that, they speculated, and I'm not sure that they know for sure, was that a consolidated lung acts more like a solid object, and you don't have pressure transmitted through that consolidation the same way you would with an air-filled lung. So you don't get that equilibration between this pressure and the midline pressure in the esophagus simply because of the level of pathology. If this were a normal, healthy person, probably not existent because we have nothing to prevent the equilibration of pressure throughout the lung. But in somebody with ARDS, pneumonia, atelectasis, consolidation, in which the lung is functioning more like a solid, object, that pressure differential does not get transmitted. So this was during active spontaneous breathing. Here they sedated the patient under controlled ventilation, and as you'd expect, that went away as soon as you took away the patient effort, that all of the pressures ended up to be exactly the same when they were under the controlled mechanical ventilation circumstance. So this, I think, is an important addition to our knowledge base in trying to evaluate how we should be managing these patients, who are breathing spontaneously, and to be very careful that we don't put them in a circumstance where they, by virtue of their ventilatory pattern, induce more lung injury than previously existed, because clearly that can happen with this type of aggressive ventilation. So their conclusion was volume assist control does not protect against injurious ventilatory patterns in spite of the same tidal volume, and pleural pressure is different during paralysis as compared to during vigorous mechanical ventilation. And as I showed, was there was a big difference between the dependent pleural pressure and the esophageal pleural pressure in the circumstances of consolidation, much different than what you would see in a healthy individual. So the other situation that I mentioned that is problematic is double triggering. Probably occurs a lot more than we realize. The biggest problem with asynchronies is if you're not standing there looking at the screen, you don't know they exist. You know, I've had the good fortune of working with Louis Blanc from Barcelona, and they have developed a algorithm that can be used pretty much with any mechanical ventilator, which gives you real-time assessment of the asynchrony. So it'll tell you immediately that this breath is asynchronous, that it's double trigger, that it's a mistrigger, that there's secretions in the airway, you know, et cetera. But it's not available yet in the United States. It's still only available in Europe. So what we did was we looked at 67 patients in which we had collected data for the whole course of their mechanical ventilation, from the time of intubation to the time of extubation. Every single breath was able to be analyzed except when they were transported out of the unit. What we found is it didn't matter if you were using pressure assist control, volume assist control with the square wave or decelerating flow pattern, you got double triggering. Also, in every patient, we saw both patient-initiated double triggering or breath stacking and reverse triggering. Now, reverse triggering is a concept that was recently discussed by Laurent Burchard, in which, for whatever reason, a control mechanical breath reflexively causes a assisted breath, that even under paralyzed circumstances, following that control breath, there is a reflex initiation of the secondary breath that results in that double triggering. So we saw both in every single patient. Twice as many double triggers as we saw patient-initiated double triggers as there was reverse triggering, but still in every patient we saw both of them. These patients were not all ARDS patients. They were not all COPD patients. There are a whole spectrum of different patients with respiratory failure in their intensive care unit. Small overall, but remember, this is 0.6% of the breaths were double triggered across every one of these 7 million breaths. You'll see, as I show you some further slides, data where some patients had significant amounts of double triggering for a long period of time. Other patients had virtually none. They'd have, you know, one here or one there, probably irrelevant, but others had a large percentage. So this is all 67 patients. This is the number of double triggers per hour on average throughout their course of mechanical ventilation. So this guy here, he had somewhere near 35% of his breaths for the whole time he was mechanically ventilated that were double triggered. Yeah, how could you not recognize that? I mean, every time you looked at the screen, you had to see double triggering. I don't know how that occurred, but clearly that one patient had that many. Others, as you can see here, 6, 8, 10% double triggering. Most had very low levels of double triggering. But then there were different patterns. These are individual patients. These are the number of hours in which we recorded data, and these represent the frequency of the double triggering. And we saw very different patterns occurring across different patients. And again, it didn't matter if it was volume ventilation, pressure ventilation, square wave flow, decelerating flow. It appeared in every one of those circumstances. Tidal volume changes, as you'd expect with volume ventilation, tidal volumes were doubled, simply because of the way volume ventilation works. Pressure ventilation, clearly tidal volumes were increased, but because you set a pressure limit, as you see here, the pressure during the second breath was not different than the pressure during the first breath, because the ventilator only allows pressure to go up to whatever you set, and then it dissipates it, so it won't go higher than that. With volume ventilation, we saw higher pressures, but clearly here was a big issue, the higher tidal volumes. This was just looking at the differentiation between the patient double triggered and reverse triggering. Although everything is statistically significant because you have 100,000 breaths, there really is very little difference as you look at the difference, in this case the tidal volume, in this case the overall pressure between the two. Basically, patient-initiated double triggering and reverse triggering in any one of these modes essentially ended up with the same set of circumstances. Just that patient-initiated double triggering is much more common than the reverse triggering phenomena. Probably because patients were mostly spontaneous breathing, much shorter period of time they were under controlled mechanical ventilation. Those things we found that were associated with the development of double triggering was short inspiratory time, low peak inspiratory flows, greater respiratory rates, greater dynamic compliance. It wasn't the patients who had stiff lungs, although there's a lot of literature showing double triggering in ARDS, but when we looked at this whole population, it was a greater dynamic compliance were the ones that had the greater amount of double triggering. And again, it occurred in all of the patients that we looked at. So there have been some studies to look at modifying it. This one published a few years ago, 50 patients, all of which they had at least 10% of the breaths were double triggering. They looked at sedating, changing to pressure support, increasing inspiratory time, or doing nothing. As you'd expect, doing nothing did nothing. Here, sedating the patient decreased it a little bit, but not anywhere near the decrease that occurred when they changed to a mode of ventilation the patient had more control over, or better adjusted the inspiratory time. And that's the problem you get into here with flow, particularly in volume ventilation. If I have a short inspiratory time, so I get a high enough flow at the beginning of the breath to prevent the development of flow asynchrony, I may end up with my inspiratory time so short that the patient's exceeds what I've set, and now I get double triggering. So it's a real trade-off between flow asynchrony and double triggering in volume control. Same thing can happen in pressure control, but a little less likely because flow asynchrony is not as frequent or as obvious because of the way pressure ventilation actually works. But that's the problem with dealing with these two very serious asynchronies, is sometimes it's a trade-off as you try to adjust the ventilator to get rid of one or get rid of the other of the problems. Mistriggering. Mistriggering is pretty common. We just don't always see it. And even if you look at the airway pressure waveform, this is esophageal pressure. This is airway pressure and flow, but measured right at the airway. So if you've got a ventilator that is a pneumotac right at the airway, you're more likely to see these little deviations than you are if you have a ventilator that measures pressure and flow inside the mechanical ventilator, because now we have all that circuit as dampening any of these pressure changes. So these subtle little changes kind of go away if you have one of those types of ventilators. If you've got one that has a pneumotac, much easier to see this as it develops. But you'll see some patients, this is a COPD patient, where you have a very consistent pattern of mistriggers and double triggers. Probably because patients who mistrigger, almost always it's because of auto-PEEP. They've developed auto-PEEP because of the way we set the ventilator or because of their intrinsic lung disease. So if we set the ventilator in a way that limits their expiratory time or gives them too big a tidal volume, they may not be able to exhale during the time allotted to bring them back to baseline. They may have auto-PEEP and they may mistrigger that first breath, but remember, after you mistrigger, you're going to exhale. So you exhale, auto-PEEP decreases, the next breath you should be able to trigger. So with COPD, it's sometimes, and I've seen this 2 or 3 breaths that you mistrigger before you're actually able to trigger the ventilator. But the same phenomena. Can't mistrigger because of auto PEEP exhales. They can go down to a lower pressure, they exhale again, even a lower pressure, and now they can trigger the mechanical ventilator. Remember, when you look at typical auto PEEP from a COPD patient's perspective, it's a result of dynamic airway obstruction. As you know, with chronic obstructive lung disease, airways are unstable and they're floppy, et cetera, so that you have that air trapping at the end of the breath. The problem is that you have that trapped gas, but on the other side of it, you have whatever you set on the mechanical ventilator. And if the PEEP level on the ventilator is set at 0, and I've got 15 of auto PEEP, I've now got a huge pressure gradient that patient must overcome in order to be able to trigger the mechanical ventilator. So if this is the phenomena that causes the auto PEEP, applying PEEP should minimize the problem. Now, this example from Marini put 15 on. If you put the same level, you usually get more overdistension. It's somewhere around 75 to 80% seems to be the maximum level of PEEP you can apply without causing overdistension. So what we have people do is just very slowly apply PEEP. This is what people have used to explain why that works. Because you have auto PEEP, but you have a critical pressure level. And as long as I keep my pressure below that critical pressure level, I'm not going to affect the upstream pressure or the auto PEEP level. If I exceed that critical pressure and get into here, I'm going to affect, the upstream pressure. So adjusting slowly PEEP level, and I recommend, we usually start at 5 and then increase in 1 or 2 centimeters of water steps until the patient is able to trigger every breath. As long as they can trigger every breath, I'm happy. I may not know what the auto PEEP is, because as you're well aware, it's almost impossible to measure auto PEEP in a spontaneously breathing patient unless you put an esophageal balloon in. So we may never know how much auto PEEP they have, but if I slowly increase PEEP until every time the patient contracts their diaphragm, they trigger the ventilator, then I fix the problem. So I have staff palpate the diaphragm, count the patient's respiratory rate, look at the ventilator, see what its response rate is, and when the two of them are the same, then stop. You've hit the right threshold. Now the patient should be able to trigger most every breath on an ongoing basis. This, in relationship to ventilator settings and these types of asynchronies, what I have tried now to get across to people is that when patients seem to be dysynchronous or have problems, people want to do more and take over more, higher pressures, higher volumes, higher whatever. Doesn't normally work. It may be that you have to pull back and actually do less in order to eliminate that level of asynchrony. I'm not saying that increasing isn't the right thing in some patients, but there will be patients that the best thing to do is to drop the pressure, particularly pressure support and pressure assist control. We tend to use, I believe, much higher pressures than we should. As you know, the whole discussion about driving pressure, I don't believe there's anybody, I shouldn't say anybody, there's a rare patient that needs a driving pressure higher than 15 centimeters of water. If we get the PEEP right and we get the tidal volume correct, we shouldn't need more than about 15 centimeters of water in order to drive the volume into that patient, regardless of what the etiology of the respiratory failure is. So if we manage things and do that, we should be able to minimize the amount of auto PEEP. This was a study now 10 years ago by Laurent Brochard's group, 12 patients, 10% of the breaths ineffective triggering. They were on high levels of pressure support. They decreased the pressure support from 20 to 13. The tidal volume went from 10 to 6, and the mistriggering was totally eliminated. They were just overinflating these patients. Their normal ventilatory response was not such that they had a long enough expiratory time to exhale back to baseline. They mistriggered. Then they got another breath, they mistriggered, got another breath. But decreasing the level of support corrected, those problems. So keep that in mind as you look at this. Sometimes, as I said, decreasing things can make a huge difference. Cycle asynchrony is simply that the ending of the breath does not coincide with the patient's desire to end the breath. So we should not see in pressure-targeted ventilation a spike in pressure at the end of the breath. If we see a spike in pressure at the end of the breath, that's telling me that the patient is activating their abdominal muscles, their accessory muscles of exhalation, to force exhalation to occur. In other words, the patient wants to start exhaling here, but the ventilator is not allowing them to exhale till you get to this point. So that can be a very uncomfortable, situation, because if this happens, it's happening every breath. You'll see as you look at it, it's not one breath here and one breath there. It's every single breath is like this. And think about it yourself. If you had to contract your abdominal muscles to exhale every time, that's a lot of effort. It's not inspiratory effort, but it's still a lot of effort on the part of the patient to be able to do that. Martin Tobin, years ago, showed that when he looked at the EMG of the abdominal muscles, that patients were starting to exhale before this point. So the patient started to exhale here, the ventilator allowed exhalation, at that point. So what we have available on, and I believe it's on all new generation of mechanical ventilators, some mechanism in pressure ventilation, pressure support specifically, in order to change the criteria to end the breath. Pressure support ends the breath when the peak flow decreases from the peak level to some predetermined percentage. Historically, that percentage was 25%. The new ventilators allow you to adjust that up and down to whatever seems appropriate for the given patient, and some give you a wide level of adjustment that's possible. In pressure assist control, you can adjust inspiratory time to accomplish the same goal in very small, tenth of a second increments in order to ensure that the patient and the ventilator are exhaling simultaneously. But the secondary cycling mechanism in pressure support and pressure assist control is an increase in pressure, as we saw. That's why the breath ends. Every ventilator's got an algorithm that if the patient pushes against the ventilator in pressure support after so many milliseconds of the breath, it'll transition to the expiratory phase. So they're ending the breath on this criteria instead of on the primary criteria that the breath should be ended. So depending upon your ventilator, it's called eSense, termination criteria, expiratory cycling, different terminology used by different manufacturers to imply the same thing. A control that sets the percentage of the peak flow that terminates the breath. So if it's set at 10% and the peak flow is 80, when the peak flow drops down to 10, the breath ends. If I adjust it to 25, now when the peak flow goes to 25% of that, or in this case, 20 liters per minute. If I set it at 50%, when the peak flow goes down to 40, the breath ends. COPD patients, this is pretty much the range. You'll find most of them somewhere in that 40 to 50% range is necessary because of their ventilatory pattern. They never have a normal ventilatory pattern, as you know. They tend to interrupt inspiration to go right to the expiratory phase. They never have that slow deceleration back to zero flow like every one of you have as you're breathing, in a relaxed state. They tend, particularly the ones who are being mechanically ventilated, will interrupt inspiration and abruptly go to exhalation. So they tend to do better when you have a relatively high termination criteria. And you can see where that is by just adjusting it up or down in order to get the patient to acclimate better to the gas delivery. I wanted to mention a little bit about SIMV. Now, my bias is that SIMV is a historical mode and it should be a retired mode of mechanical ventilation. And I realize there probably are people who have very different opinions in this room, and I'll accept your opinion. Let me make my case first. So this is early work by John Marini. And what they did was they looked at a series of patients on SIMV. They went from 100% assist control all the way to CPAP. They measured the amount of work done by the ventilator and the amount of work done by the patient. So one would expect, if I decrease the amount of mandatory ventilatory support, that the amount of work the patient would do would go up. But why would the amount of work the ventilator does also go up? And that's the amount of work the patient does during the mandatory breath. And you'll notice both increased. Patient work and the work that the patient did during the mandatory breath. Both increased as the percent of support decreased. Which breaths are mandatory and which breaths are spontaneous? So you've got EMG signal, you've got esophageal pressure. Pretty hard to tell, which one is the mandatory breath or which one is the spontaneous breath. If I were to look at this and know nothing, I would say this is probably a mandatory breath because it was less pressure. But I would be wrong. It's a spontaneous breath. Patients, as you get to a mandatory rate somewhere around half of the breaths being mandatory and half of the breaths being spontaneous, patients essentially do the same amount of work regardless of whether it's a mandatory or spontaneous breath. The respiratory center cannot readjust rapidly enough to change its perception of the load that is being imposed on it. So it assumes every breath is the heavier load, every breath is like a spontaneous breath. So patients will tend to breathe with increased effort during the mandatory breath as they do during the spontaneous breath, which is probably the reason that SIMV has always been shown to be the mode of ventilation that prolongs the weaning process instead of shortens the weaning process, because we don't give patients the opportunity to rest. As we decrease the rate, patients are going to work constantly at a specific level. The concept that these individual breaths rest the patient is just simply not been supported, by the literature. PAV and NAVA, just one quick slide. They do work differently, but both, have showed improved patient synchrony, improved patient comfort, even in the settings of changing ventilatory demand. So ideally, these are the modes I expect in the future we will probably be using more and more in spontaneously breathing patients, or at least modes similar to this. Not saying they won't be adjusted and modified, but modes similar to these because they result in the best interaction between the patient and the mechanical ventilator. So let me finish by going through some studies that show an association of asynchrony with poor outcome. Remember, it's going to be awful hard to have a randomized controlled trial to look at asynchrony, because how do I set up a trial that one patient I optimize the way they're ventilated and the other patient I give them a poor ventilatory approach to create asynchrony? So I'm not sure we'll ever see a randomized trial, but we're seeing more and more data that shows a relationship or an association of asynchrony with poor outcome. These are the first two studies, and they looked at an asynchrony index of greater than 10%. Now what that means is that 10% of the patient's efforts were asynchronous. Missed triggers, double trigger, whatever the case may be, they were asynchronous. So 10% overall ended up to be asynchronous in the patient's overall activity. This group from Laurent Burchard showed an increased length of time of mechanical ventilation to those with a high asynchrony index. This group showed an increase in the length of ICU stay with a high asynchrony index. This was an abstract, and I've not found the full paper. Interesting, because they looked at 30 patients. They did recordings of every breath for those periods for approximately 79 minutes across the board in the 30 patients, but they also videotaped the patients during that period. And what they found was, as you'd expect, that during asynchronous breaths, there were changes in ventilatory muscle patterns, etc., but they also found facial grimacing, extreme motion associated with the asynchrony. So clearly some emotional discomfort associated with the process of having to deal with an asynchrony in this patient population. This is from Danny Telmore's group. Part of this has been published as a full paper. 20 early ARDS patients, 72 hours of continuous measurement of pressure and flow. They defined double triggering as a tidal volume in volume ventilation 2 ml per kilo greater than what was set. Now we can argue about that definition, and that may have been the reason they ended up with such high percentages. Where is it? One patient had 90% of the breaths were double triggered breath, but they defined it as greater than 2 ml of above the set tidal volume. And as you can see, they ventilated these patients as we would expect patients to be ventilated nowadays. The amount of double triggering from 0.1 to 90% of the breaths being double triggered. In 40% of the patients, greater than 10% of the breaths were double triggered. And when they looked at survivors and non-survivors, as you can see, the percentage of double triggering was much less in the survivors than it was in the non-survivors. So again, indirect evidence, but that evidence is starting to accumulate. This is data we published a few years ago from Louis Blanc's group, in which we looked at 50 patients. You can see the different types of analysis that were done with his algorithm to look at overall asynchronies. And this is what it looks like, on a computer screen. So this is real-time, activity of the patient. Tells you that air trapping, cycle time, all the different interpretations that they have in that algorithm of asynchronies occurring in this particular patient, real time as it's actually happening. These are the patients that we looked at. Again, a mixed bag of patients with all different types of reasons for being mechanically ventilated. If we look at the way they were ventilated, these were not patients that were stressing, the system overall. Where is the ventilatory pattern on here? Maybe it's next slide. Here, sorry. If we look at the peak airway pressure 24, plateau pressure is 19, compliance 35, airway resistance approximately 10, number of breaths over 32 centimeters of water, a small percentage. So these were patients who were not a real problem to mechanically ventilate. These weren't the ones that you would find that were extremely, difficult. This is the percentage of the different types of asynchronies we analyzed. Inspiratory time of the ventilator shorter than the patient's inspiratory time. Inspiratory time of the ventilator longer than the patient's inspiratory time. Mistriggering, double triggering, overall asynchrony index. And as you can see, across these 50 patients, across every hour of ventilation, this is the percent per hour, approximately 3 to 3.5% of the breaths were were asynchronous. This is all of those patients, looking at them for 25 days. So here you see the median and 25, 75, but here are the outliers in numbers of asynchronies per hour. So as you can see, huge number of outliers with a very high percentage of asynchronies on certain days. Obviously, as you get down here, there was less and less patients, so less and less outliers, but as you will notice, a large number of outliers that existed as you look at this database. So many patients had low levels, but other patients had very significant overall levels of asynchrony. One patient looking at the different levels, so we have again, inspiratory time of the ventilator shorter than the patient's, inspiratory time of the ventilator longer than the patient's, mistriggering, double triggering, air trapping, and asynchrony index. And you can see how it changed over, this was from hour 40 to hour 120 of that particular single patient being mechanically ventilated. Again, just like I showed with the double triggering, different patterns depending upon the patient. This is asynchrony index. And you see some patients with huge asynchrony indexes as time goes on. Others, not so bad. Other patients, don't have a big problem. It's difficult to know which ones will fall into these categories compared to falling into this particular category. We found an association with mortality. An association that patients who had an asynchrony index of greater than 10% had a higher likelihood of dying in this population of patients. Small number, 50 patients. We're now looking at a database of almost 300 where we're reproducing this analysis, which will be much more interesting data, to take a look at. This one just came out last year. This is a group out of Greece in which they looked at mistriggering. So they measured mistriggering on 110 patients on the first, third, and the 6th days of mechanical ventilation. You can see the number of breaths. All patients were in pressure support or PAV. What they found was clustering. In other words, there was a period of time in these patients where there was a significant number of mistriggers that occurred, and then other times where there was virtually no mistriggers that occurred. And they defined their clustering as 30 mistriggers in a 3-minute period, or an asynchrony index of about 35%. 42% of the patients had this type of clustering. They found that the clustering was associated with long mechanical ventilation and, again, overall mortality. And if you look at their one graphic, this is the number of mistriggerings per 30 seconds, and as you can see, you have periods of nothing, then all of a sudden, they had this period of huge amount of asynchrony, then go back to minimum levels, and then it would come again in certain patients. So what I hope, as I got across, is the fact that asynchrony is a problem. It exists in all the patients we mechanically ventilate, and we need to do a better job of looking for it and managing it. We can't get rid of it all, but we should be able to minimize it. And we can minimize it within a particular mode by making timely adjustments to the settings in that mode, or we can change the mode of mechanical ventilation. If you've never breathed on a ventilator, I really would advise you to do that. To set up the ventilator, take a mouthpiece and feel the difference between volume ventilation, pressure assist control, pressure support ventilation, because you'll understand why it's difficult for patients to acclimate who are breathing spontaneously to volume ventilation. Controlled ventilation, no problem. You can do whatever mode you want because you're in control of everything. But when the patient starts breathing spontaneously, you want the ventilator to work with the patient. And certain modes do not do that as well. Asynchrony is still present during sedation. You really have to, knock the patient out in order to get rid of asynchronies. Longer course of mechanical ventilation, longer ICU stay, and as I said, they're associated with mortality. Thank you. Questions, comments, disagreements, arguments?
One comment. A lot of the same concepts are appropriate to non-invasive ventilation, like ResMed's BiPAP and IVAPs, let you adjust cycle, trigger, inspiratory time, rise time, and it's very different from the AVAPs, Respironics.
There's no question that you have, on most of the non-invasive.
So a lot of the non-invasive things, the same concepts apply to
correct.
Effective ventilation that's comfortable.
So I even think non-invasive ventilation can sometimes be more dangerous from a spontaneous breathing perspective than invasive ventilation, just like high-flow nasal cannulas can be. Because what we tend to look at is the fact that the patient's gas exchange got better, but if you look at the patient is struggling, to breathe. If the patient is working hard to breathe and has not changed their ventilatory pattern from the time you've initiated non-invasive ventilation or high flow nasal CPAP until an hour or two later, particularly if that patient has hypoxemic respiratory failure. We probably aren't doing that patient a favor by keeping them on either of those two modes. So you're right, all this pertains to non-invasive ventilation, and we should be very careful and not to extend it longer than we should. That one study that was done by Esteban that was published in the New England Journal of Medicine, where they looked at post-extubation respiratory failure, where they randomized patients to non-invasive ventilation and to regular oxygen therapy, there was a higher mortality in patients who were managed with non-invasive ventilation. But the big difference was that patients who were managed with non-invasive ventilation didn't get intubated until 8 hours, where the patients who were on regular O2 therapy got intubated within an hour or two. So they speculate that patients were struggling to breathe on non-invasive ventilation for a long period of time and developed lung injury in the process. So you are absolutely correct. This goes for, theoretically, any patient with significant lung injury, if they're allowed to, breathe with a very, aggressive ventilatory pattern, can create the problems that I showed you, from that study, from Amato. You can create those huge transpulmonary pressure gradients, and if you've got consolidation or atelectasis, the same thing's going to happen if you're breathing spontaneously or if you're breathing under mechanical ventilation. So we should be careful, with patients with non-invasive ventilation, just as we should with patients intubated.
Do you use stress index at all?
The stress index? So we haven't used the stress index because we look at driving pressure. Okay. So we try to set the PEEP. We're a little more aggressive with PEEP and lung recruitment, so we have higher PEEPs than many others do. We try to keep the driving pressure below 15, and we found that if we get the PEEP right and we get the tidal volume right, we're able to keep the driving pressure below 15. The problem with the stress index is, boy, it's your eyeball, to be able to determine whether it's up, down, or whether it's, if the ventilator gave you that data, in which they easily can do, and I don't know why they don't do it, because they could easily analyze, the waveform and tell you what the stress index is without much of a problem, then it would make it very, to me, useful. But now it's difficult, because I look at it and I get one interpretation, you look at it and you get another interpretation.
My question, I'm one of the fellows. My question about the NAVA and the PAVA, should you use them more? And according to your experience, do you use them right now? Is with other cases that you could point out that you just right from the beginning that you use them? We don't have a lot.
So using PAV, did you say?
PAV and NAVA, yeah.
Yeah, I think
more. And is there cases like that coming in mind that you would start them as a primary mode of ventilation? They're just no, we need to put them on PAV.
Yeah, I think you should use more PAV personally. Now, you've come to Mass General, you won't see them use more PAV. The problem is you have no control over the patient's ventilatory pattern and use PAV. And as a result, people get very nervous because the patient chooses to breathe with a tidal volume of 200 ml, 45 times a minute. Now, that may be okay or that may not be okay depending upon the particular patient's circumstances. But you can't force a ventilatory pattern with PAV. So a lot of people don't like it. But I tell staff, any patient you would be willing to put on pressure support, you can put on PAV. If the patient meets criteria for pressure support, they meet criteria for PAV because the same type of backup exists with PAV as it exists with pressure support. It's just that it's a different mechanism of delivering it. If you breathe on the ventilator, some people like pressure support better, some people like PAV better. Personally, I think PAV is very easy to breathe with. You don't even feel that you're being mechanically ventilated with it as you breathe with it, because it follows your lead. And when you decide to stop, it automatically, stops. So I would say most people do not use as much PAV as they should, and it does deal with asynchrony to a very significant extent. And obviously, we don't have time to go through the literature, but the thing that shows up in all the articles with PAV and NAVA is decreased asynchrony. And it's usually compared to pressure support. Pressure support, most people would assume, has the least asynchrony, but PAV and NAVA have even less asynchrony than pressure support.
can make great measurements with a patient or animal paralyzed. And it's something we have the option of doing in clinical practice. But most of what you described doesn't require neuromuscular blockade to effectively ventilate.
Correct. See, I don't think, yeah, I mean, for research purposes, we usually neuromuscular blockade patients when we do put balloons in and do studies. But clinically, they just have to be passive. You know, we'll put balloons in for PEEP titration, you know, for looking at the peak transpulmonary pressure, but I don't think they need to be or paralyzed, just passively ventilated. So if you sedate them till they're not actively breathing, and obviously if you got the balloon, you know for sure that they're not actively, the breathing gives you good data. Are you using esophageal balloons much?
A little.
I mean, unfortunately, it's a skill set that takes a little bit of time, technically, you know, and interpretation-wise to get. But I think you'll find as you start doing more and more of it, it's really provides you with useful, you know, information to manage these, particularly, not everybody, but the ARDS patient, we find it most useful in obese patients. I mean, we're always amazed when we put a balloon in how much PEEP you need to use in order to get the transpulmonary pressure positive. I mean, sometimes it's almost 30, you know, centimeters of water to get a positive transpulmonary pressure in these obese patients, which you'd never do unless you had that direct, you know, feedback that this was an appropriate thing to do. So I think it'll be used more and more, except it's not easy to do is the problem.
We tend to use it in the supermassively obese, but I'm curious, is there a threshold at your institution for a BMI or some?
So we're looking at usually 35 to 40 BMI, you know, and above that we will do it. As we recruit patients for our studies, those are the levels. And because you can do, like we do recruitment and decremental PEEP trials, you can do that without the balloon and get basically the same results. But having the balloon there makes you feel much more comfortable, you know, that putting them on these real high levels of PEEP is really appropriate, you know, for that patient. Yes?
You mentioned using applied PEEP to overcome auto PEEP to minimize asynchrony. In COPD patients, would you use that as well in an asthmatic?
The asthma is a little tougher answer to give you because remember, the obstruction in asthmatic is not a variable obstruction, it's a fixed obstruction. So in some patients, you can titrate PEEP up and you hit a sweet spot and things get better. Others, never happens. So it's an experiment.
So you titrate and see your...
If there is an issue and you really need to try it, yes we do, but I wouldn't say we do it on a regular basis. I would say normally we keep very low levels of PEEP with asthma because we found it's very few, you know, patients that it actually works on. That if we titrate PEEP, we still don't see things open up.
In the COPD population, you said you titrate PEEP and you use your hand essentially to see if you effectively relieve.
Right.
Do you follow plateau pressures as well in these patients, or?
Sure. But I mean, I have them palpate the diaphragm because it's difficult to get the patient's rate, you know, unless you really feel what the patient's breathing. Because the ventilator, it doesn't tell you all those little, you know, patient efforts that are mistriggered. So it's better to truly count the patient's rate, and then truly look at the ventilator rate, and when the two are equivalent, then you've got it right. So that's the only reason, because I just can't get the rate accurately any other way. Okay, thank you very much.